Hello and welcome to another session of the Renal Rounds. Today we are going to talk about an issue which has been discussed for quite some time, that of chronic calcineurin inhibitor toxicity. How important it is and how worried should we about it. Before we go there, I think it's useful to remind ourselves of the history that in 1976 the biological effects of cyclosporine were identified by Jean Borel and his team. They were working for the pharmaceutical company Sandoz at that time, which subsequently has now become Novartis. And this paper was published, and this particular set shows you the figures in that particular paper and the tables. And individual figures are not really important, but basically what it shows is the effect of cyclosporine on lymphocytes, and it was thought to be something that could be useful in modulating the function of lymphocytes, especially when they become important for immune response. So we fast forward just a couple of years, and this photograph shows Sir Roy Khan, one of the giants of transplantation medicine, and he and his team published the effect of cyclosporine in patients who received cadaver renal allografts, which are now known as allografts from deceased donors, in the Lancet in 2078. And subsequently, 4 years later, again, the Lancet published this paper describing a multicentric clinical trial conducted in Europe. Again, the use of cyclosporine as a sole immunosuppressive agent was limited to deceased donor organ transplant recipients. So since then, cyclosporine pretty much became the standard addition to the currently prevalent immunosuppressive regimen, which was azathioprine and prednisolone, until the early 1990s, when a new drug, which was at that time called FK506 and currently we know as tacrolimus, became really known. And this paper was published from Tom Starzl's group in a relatively less important journal called Transplantation Proceedings. It is published even today, which described the role of this particular molecule in kidney transplantation. And of course, tacrolimus is the one that we use much more commonly today. So with that historical background, now let's come to the issue of the calcineurin inhibitor toxicity and the history of that particular entity. And again, this goes back to this paper which was published in Transplantation Proceedings by Michael Mihash and his team. They described arteriolar hyalinosis in cyclosporine-treated subjects, and they said that this lesion was not found in healthy kidney donors, and therefore this lesion must be caused by cyclosporine and was subsequently dubbed as cyclosporine toxicity. But let me remind you that in this particular paper, the patients who received cyclosporine in what would be considered now supratherapeutic dose with cyclosporine trough levels. Please note that these are not 2-hour levels, but trough levels of 1000 to 1500 nanograms per milliliter. However, the description of morphological patterns in this paper pretty much became the standard to identify cyclosporine toxicity, and subsequently carried over to a broad group of calcineurin inhibitors, which included tacrolimus as well. And these are the morphological lesions which are typically dubbed as chronic calcineurin inhibitor toxicity. And this particular slide shows you this arteriole which has this eccentric hyalinosis, and the glomerulus which shows chronic lesions. So this was also part of the constellation of lesions under chronic calcineurin inhibitor toxicity. And of course, at relatively low power, you are able to appreciate what is typically described by morphologists as striped interstitial fibrosis. And this is also thought to be one of the characteristic lesions of calcineurin inhibitor toxicity. And when we see these lesions, our pathologists would mark that particular case as having chronic calcineurin inhibitor toxicity. Well, one of the situations that further substantiated this view was the presence or development of kidney dysfunction in patients who received non-renal solid organ transplantation, like heart transplant, etc. And this description also came relatively early from this group in a paper in New England Journal of Medicine, in which they described 12 patients, 17 recipients of heart transplants, and who received cyclosporin, and compared them with 15 heart transplant recipients who were treated only with azathioprine. And they found that patients who received cyclosporin were more likely to develop a reduction in renal plasma flow and glomerular filtration rate, and thereby once again they said that these patients are likely having chronic cyclosporin associated nephropathy. Please note they use the term associated, not induced. But also worth mentioning is that in this paper also the patients treated with cyclosporin had relatively high trough levels of 300 to 350 nanograms per ml. Since we all recognized at that time that with the introduction of cyclosporin, the acute rejection rates came down. However, the rates of long-term graft survival did not improve very much, at least in the 1990s and early 2000s. And therefore, the long-term attrition in graft survival was attributed largely to chronic cyclosporin toxicity. And at that time, as this paper in Kidney International in the 1990s says, this condition was considered to be the Achilles heel of immunosuppressive therapy. So much so that it became practice in many parts of the world to either reduce the dose of cyclosporin or even take it off completely in patients who were thought to have passed through the riskiest period, which was considered the first year of transplantation. And this paper we published in the American Journal of Kidney Diseases in 2001, and Dr. Thangamani Muthukumar, who is now a faculty member at Cornell University in New York, actually described the outcome of these subjects who had cyclosporin withdrawal at the end of 1 year. And we found that after withdrawing cyclosporin, these patients had a higher risk of acute rejection, which meant that obviously cyclosporin withdrawal was causing harm also. We of course did not know, or at least did not describe in this paper, what happened to these subjects in the long run. Now, from there, let's come to this very, very influential paper which was published in the New England Journal of Medicine in 2003. And the two people I want to point out is the first author, Dr. Brian Nankerville, and the last author, Dr. Jeremy Chapman, who is well known in India. He has visited us and has participated in a number of educational activities, etc. here. So in this particular paper, these authors described the outcome of 120 kidney transplant recipients. And what they showed is that when they did protocol biopsies in these subjects, they showed that over a period of years, chronic interstitial fibrosis and tubular atrophy increased and contributed to increase in the mean Banff score in these individuals. So you can see this is the chronic interstitial nephritis, tubular atrophy, and arterial hyalinosis. And classically, as I said before, these are the three lesions which are together described as characteristic of chronic calcineurin inhibitor toxicity. They also showed increase in fibrointimal thickening and chronic glomerulopathy, but that did not increase so much over the 10-year observation period in that particular study. And so they said that as if you go through the timeline starting from 0 to 10 years after transplantation, the prevalence of calcineurin inhibitor toxicity increased over time, and it became almost 100% at the end of 10 years. This is what that same paper shows, but what I want to really point out to you is that in this particular paper, grade 1 lesions were described as early as 1 year after transplantation in more than 90% of subjects. So this is something which is really important for us to remember and was not emphasized so much, is that whatever lesions are developing, whatever be the cause, they are developing in the first year after transplantation. So if the cause was really chronic damage due to cyclosporin, then it should have occurred over a period of time as well, and it should have continued to progress. So the progression was only in the severity that those with grade 1 lesion perhaps went and developed grade 2 lesion, but there were, it seems, very few people who did not have any grade 1 lesion at the end of 1 year, which is kind of surprising and worth pointing out. So what this had done during these years is attempts for the global transplant community to minimize exposure to calcineurin inhibitor, and a number of regimens, some of them we will talk about later on also, were tried in clinical trials. And we also tried one of those, and this we published in 2013. This work was led primarily by Dr. Dinesh Bansal at PGI Chandigarh, and there we tried to switch patients from calcineurin inhibitors to sirolimus, and we thought that that would be a good thing. So obviously they exhibited improvement in GFR, which is not a surprise because calcineurin inhibitor has an acute effect on the arterioles, which leads to reduced GFR because of vasoconstriction. And when you take away that vasoconstriction, the GFR will improve, but that is just a vasomotor phenomenon rather than a true improvement in GFR. But we also showed at that time that sirolimus had an independent effect and favorable effect on T regulatory cell population, which was different. But of course, this trial was limited to 6 months period, and so we were not able to ascertain the long-term effects of this switch. So having given you that background, the first thing to say is that we all know that, and there is no doubt that acute calcineurin inhibitor toxicity exists. We see it every day. We have transplant patients in early weeks after transplantation. Sometimes you will see their creatinines going up, and when you get their cyclosporin or tacrolimus levels, they are high, and when you reduce the dose, the creatinine comes down. So that is a very clear indication that calcineurin inhibitor toxicity in its acute form exists. Now this particular slide shows you the typical lesions that have been described in association with acute calcineurin inhibitor toxicity, which is these isometric vacuolation of tubules. But let me also emphasize that these lesions are not at all specific for acute CNI toxicity, and there are a number of other conditions which can cause this microvascular changes in tubules. But acute CNI toxicity is a clinical diagnosis. Now, over a period of time, we do know, and this is data from US SRTA registry, which tells us, and I said this before, that the kind of CNI that we use predominantly now is tacrolimus, and cyclosporin is used in very, very small number of subjects. And this particular slide shows you also that contrary to the old phenomenon that we continue to say that the long-term graft survival has not improved, you can actually see that 10-year graft survival is improving, and the percentage of people who die at the end of 10 years has progressively come down from 2000 to 2008 or so. The decline is not massive, but it is there, so we shouldn't really discount that particular phenomenon. Now, since then, there are a number of papers which tell us that there are, contrary to Michael Mihash's earlier paper of the specific histological lesions for CNI toxicity, there are no such lesions. So going back to the paper by Nankivel et al., I just want to once again remind you that these were very, very selected subjects. So all subjects had type 1 diabetes, and all but one had received simultaneous pancreas kidney transplantation. It's important to point out that these pancreases were all bladder drained, and because of the release of enzymes in the bladder and the fact that reflux can occur in the grafted kidney, development of chronic tubulointerstitial lesions cannot necessarily be ascribed to calcineurin inhibitor use in these subjects. Moreover, there were no control group for us to say whether this did not develop in someone who did not receive cyclosporin. And despite the lesions that they described, these patients had really excellent 10-year graft survival of more than 95%. I apologize for the error here. It shouldn't read years; it should read percent. Uh, then there are other papers also which show that arterial hyalinosis, once again, which was so far thought to be specific for chronic CNI toxicity, can be found in individuals, almost two-thirds of individuals who were never exposed to CNIs. Of course, the frequency in those who get CNI is somewhat higher. Uh, and other studies have shown that it is actually the acute rejection episodes and low tacrolimus levels, or low CNI levels, which are independent risk factors for chronic pathological lesions rather than the dose of CNIs. Here is one more study from Dr. Arthur Mattis's group, and over a 12-year period, they followed 1,263 subjects who underwent a first kidney transplantation. And what they described is that in subjects whose graft survived for more than 1 year, the annual mean serum creatinine remained stable for really long periods of time, and their actual 20-year patient survival was 38%. And so they concluded that that a large number of kidney transplant recipients tolerate long-term CNI and maintain stable serum creatinine levels. And so at that time, they sort of raised a red flag and said that we should really try, rather than to say that all the chronic changes are due to CNI toxicity, we should try to identify who might be the individuals who are susceptible to it. Here is another paper, which is a meta-analysis published in New England Journal of Medicine in 2003, which looked at chronic kidney disease after transplantation of a non-renal solid organ. And the conclusion of that paper, or the abstract of that paper, shows that in multivariate analysis, an increased risk of chronic kidney failure was associated with increasing age, female sex, pre-transplant hepatitis C infection, hypertension, and post-operative acute kidney injury. Please note that missing from this list is the use of calcineurin inhibitors or even the dose of calcineurin inhibitors. And so they said that CNI use was not a significant predictor, nor was the use of an organ-specific CNI target level. So this is really very important. If some more data on CNI use and kidney dysfunction in other extrarenal organs. So in liver transplant, there was no difference in kidney function between high and low level CNI groups. And when actually they did protocol biopsies in these liver transplant recipients, they found that individuals who were transplanted had silent glomerulonephritis rather than CNI toxicity. So even if chronic kidney disease develops, it may be due to some other cause. Now, one other thing which is used as an argument to support chronic CNI toxicity is that patients who do not have any kind of kidney disease at all and have autoimmune disease like psoriasis and uveitis, when they receive cyclosporine, they can develop chronic kidney disease, which is true, and that is something which we need to study more. But please also remember that psoriasis and uveitis are autoimmune diseases, and autoimmune conditions can produce kidney injury independently, and that doesn't have to be necessarily ascribed to CNIs. But it would seem, in summary, that CNIs perhaps do play some role in both acute and chronic kidney injury, but their true contribution remains unknown. Now, here is another paper from the same group of Dr. Brian Nankivell and Dr. Jeremy Chapman, which looked at mycophenolate, and they said that mycophenolate alters kidney transplant histology. So it's really interesting in the way they present their findings. They said that MMF therapy was associated with limited chronic interstitial fibrosis, stripe fibrosis, periglomerular fibrosis, mesangial matrix accumulation, and chronic glomerulopathy scores. They also said that MMF use reduced arterial hyalinosis, stripe fibrosis, and tubular microcalcification. So these are the lesions which they had ascribed to CNI toxicity. But what is surprising here is that all these patients did receive the same CNI, but just when they did not receive tacrolimus, azathioprine, but received mycophenolate mofetil, the lesions became less severe. Why should that happen? If it is because of CNI should actually continue to cause the same lesions. So it's really one wonders whether these lesions are truly due to CNI toxicity or have been due to other factors which we described earlier, because those are simultaneous pancreas kidney transplant recipients, etc. Now let's come to the knowledge that we have from the use of CNI elimination protocols. There are a number of studies which really with really fancy names. So we had the concept study, we had the spare the nephron trial, we had the convert trial, and we had the Caesar studies. These are only a few of those. There are many more. Summary from these studies is that CNI withdrawal was associated with better kidney function in at least one study, but not the other two. Uh, in convert study, a late CNI withdrawal was halted prematurely in individuals who had GFR between 20 and 40 because the outcomes became poorer in those. In concept study, late CNI withdrawal was harmful in those who had proteinuria, and in Caesar study, the allograft function was similar in all the three groups, which are shown here, but the biopsy-proved acute rejection was higher in those from whom cyclosporine was withdrawal. Many of you, I'm sure, are aware of the ELITE Symphony study, which was published in the New England Journal of Medicine. And this study was led by Dr. Henrik Ekberg, who sadly passed away while biking in Bangkok rural areas. At that time, he was the president-elect of the Transplantation Society. Now, the ELITE Symphony study was a randomized clinical trial, which was a 4-arm study, and subjects received either standard dose cyclosporine, low dose cyclosporine, low dose tacrolimus, and low dose sirolimus. And in the groups B, C, and D, these groups had received daclizumab, which was an interleukin-2 receptor antagonist. What they showed is that the probability of biopsy-proven acute rejection was highest in the group that did not receive any type of calcineurin inhibitor, and it was lowest in the group that received tacrolimus. It was intermediate in the group that received cyclosporine. And the probability of allograft survival was also lowest in those who received sirolimus. So it again proves that it is actually a calcineurin inhibitor which is associated with better graft survival rather than any attempt to withdraw a calcineurin inhibitor and replace it with something else such as sirolimus. So other studies have shown that CNI avoidance with sirolimus does not lead to any benefit in GFR or graft histology. And there is RCT evidence comparing sirolimus MMF prednisolone and tacrolimus MMF prednisolone, similar 1-year graft survival, no difference in measured GFR, and no difference in IFTAR glomerulosclerosis. RCT evidence also shows that sirolimus, along with low-dose tacrolimus versus sirolimus and CNI-free regimen, shows no difference in chronic allograft damage index at 1-year protocol biopsies, and recipient graft survival are similar at 5 years. Orion study in which cyclosporine TAC followed by TAC elimination, cyclosporine MMF, and TAC MMF were the three groups that were compared. Sirolimus MMF group was actually terminated due to high biopsy-proven acute rejection. So again, it repeatedly shows that the drug that you really need to be continued is a calcineurin inhibitor. And this is the summary of these studies, and if you're interested, I would draw your attention to this particular paper by Dr. Issa et al., which was published in the American Journal of Nephrology. There is also a Cochrane review on this, and the Cochrane review shows that long-term outcomes for stopping or reducing CNI therapy are not clear, and that and there were insufficient studies for long-term follow-up. So, having done all of this, you will say that that patients are actually losing their grafts in the long term. So, what is causing them to lose their allografts if it is not CNI? And here we need to go back to some of the other principles that you have, for example, in crime detection. In crime detection, if you say that if there is one suspect, and if you want to argue that that suspect is not actually the criminal, what do you need to do? You need to find the real culprit. And so let's see what exactly is the real culprit. And there is increasing evidence that it is alloimmunity rather than CNI use, which is the major cause of later allograft failure. And we won't talk about it too much because that will require another 1 hour. But just to show you a few studies in this paper, which again came from Dr. Arthur Metis' group, which actually said that there was strong evidence for antibody-mediated injury as the major determinant of kidney allograft failure. The conclusion of this particular paper is that antibody-mediated injury is common in patients with new onset late kidney allograft function, and allograft failure is much more likely to happen if C4D staining is positive. Here is another paper which tried to identify specific causes of kidney allograft loss, and they actually said that they were able to identify a specific cause in most patients who exhibited allograft loss late in the course of kidney transplantation. And their conclusion was that contrary to current concepts, most cases of kidney allograft loss have an identifiable cause which is not CNI toxicity. And they say that glomerulopathologies were the largest cause of graft loss, and alloimmunity remained the most common mechanism leading to failure. One more study which showed that donor-specific antibodies accelerate atherosclerosis, and other studies, the histology of solid organ transplantation, and some more studies I'm showing you here, which have appeared, and I'll show you data from just one of those studies, which is the first one, which here computes the long-term survival of individuals who were either DSA positive or DSA negative. And these are the two arrows which shows you the slope of serum creatinine rise or decline in GFR. And this is the slope in individuals who are DSA positive, and this is the slope in individuals who are DSA negative. And you can see that the slope is much more vertical in those who are DSA positive, indicating a more rapid worsening of kidney function. And this is another figure from the same paper which looks at individuals who are persistently DSA negative, individuals who had DSA positivity at the time of biopsy, and individuals who, at the time of transplantation, and individuals who developed donor-specific antibodies later. And again, those who either had DSA at the time of transplantation or those who developed DSA later, they had much more steeper decline in kidney function compared to those who remained persistently DSA negative. And the final piece of evidence comes from not histology, etc., but from genetic studies. And now you might know that Dr. Philip Halloran's group from Alberta has this project called molecular microscope. And in this, what they do is that they take the kidney biopsy, and rather than looking at them under the microscope, they extract RNA from it and look at transcripts. And what they have done is that, again, in a series of biopsies which have extended from 5 days to 10,000 days, they have shown that gene transcripts show in early stages that most of the grafts are normal, but the proportion of grafts with no major abnormalities comes down over a period of time. And what increases over a period of time is this non-specific graft failure, and this is the line of antibody-mediated rejection. So this is important. But what is missing from this figure is, and this box, is any pattern which indicates CNI toxicity. Again, suggesting that antibody-mediated rejection triggered in some cases by non-adherence is the major disease causing late allograft failure, and pure chronic CNI toxicity rarely explains failure. And because of this finding, they say that since ABMR is so important, we should not try to reduce the dose of immunosuppressive drugs over a long period of time. And I would like to reiterate that point is that at this time, the most important drug that we have in our armamentarium for treating patients with who have received kidney transplantation is a calcineurin inhibitor. And we must have really very, very strong reasons to either reduce the dose of calcineurin inhibitor or to take it off completely. And this is not to say there cannot be any reasons. Obviously there could be reasons like development of thrombotic microangiopathy or development of a malignancy or other such reasons, and we will be fully justified, or severe infection, where we'll be fully justified in withdrawing these agents. But otherwise, let me just end by making this conclusion that late allograft failure remains a major problem in kidney transplantation. I hope I have been able to present to you significant data that confirms that CNI toxicity has been highly exaggerated as a cause of chronic allograft dysfunction. And there is increasing evidence that it is actually alloimmunity, which means donor-specific antibodies, which is the major mechanism of late allograft failure. And we should really concentrate on reducing that. CNI-based immunosuppression remains the proven standard in kidney transplantation. The findings, which were so far thought to be specific for CNI, chronic CNI toxicity, are really non-specific, and most of the data argue against CNI avoidance or minimization. But of course, as we always say, that more research is needed to understand the true cause of chronic allograft loss. Thank you very much for your attention.